every committee meeting. And who just came on? We have a new person.
It's Alexis Cordiano. I couldn't join via the video. It kept saying the site we reached. So I apologize, but I joined because the audio let me in.
Oh, okay. Well, we're glad to have you. You can be heard just fine. So
perfect. Thank you.
Yeah. So welcome everyone. Just as a reminder, this meeting is being recorded and it will be available for viewing on the Judicial Branch YouTube channel. So I wanted to get that out of the way. You all should have 4 handouts. You should have the agenda, the May minutes, the committee, the list of committee members, the current list, as well as the remaining meeting schedule for 2021. A couple of meetings left in this fiscal year. So I hope everyone had a chance to look at the May 12th minutes. And so what we need to do is have a motion to accept.
So moved?
Yes. Did someone say so moved?
Who said that?
Hi, Marielle said so moved, if that helps.
Okay.
Second?
Yes. Is there a second?
Yeah, Brittany.
Brittany. Okay. So any discussion? Okay, hearing none. Let's take a vote. Can you just either raise your hand, because I can't see everybody, or say yes?
Yes.
Yes. Yes.
Yeah.
Any nays? Any nays? Any abstentions? Okay, May minutes are approved. Okay, I'm going to do what Linda did a couple of meetings back, and I'm going to pull the prerogative of the chair because I'm chairing. Obviously, Linda is not here today. And Heather, could you give an update with regard to the Connecticut Emergency Nurses Association? I know you have a July 21st meeting coming up, and I know you may not be able to stay for the whole meeting. So could you just go ahead and give your update?
Sure, thanks. Hi, everybody. Hope everybody's having a good summer so far and safe. So the update is just that we're trying to figure out which meeting or conference, that's the word I'm looking for, we were going to have to invite you guys for just an introduction of the SAFE program from Connecticut. So we also have the Ascend, which is our annual conference. So we might have a table at that. And we do have a meeting scheduled. I think it's actually tomorrow. Today's Wednesday, right? Yeah, it might be tomorrow for that. So I can definitely know more, hopefully, for our next meeting. But that's where it stands right now.
All right. Thank you so much, Heather. Any questions for Heather on that?
Sounds good.
Okay. So Edith, on the next thing on the agenda was actually an update on the revision of the DPH pamphlet, and it was find it here. Edith left a message saying she would not be able to make it. However, she wanted to provide a little bit of an update, and so she sent this, and I'm just going to read it to you. I wanted to provide you with an update pertaining to the SAFE Committee Information Sexual Assault Resource Packet for the emergency rooms. And she shares that Lori Johnson of Converge Marketing was selected and approved to work with DPH on this project. And she's looking for, they list some days and times to work out the details. And then she included Beth the Alliance on that communication. So we're moving right along with that, which is great. It'll be nice to have that done. And so hopefully she'll be able to make the next meeting and we'll have more information at that time.
Can I just make a comment? Sorry, it's Alexis Cordiano. I can't see people, so I apologize, but I assume it says emergency departments, right? We should be referring to emergency departments, not rooms at all, because obviously many departments have over 100 beds in the state.
Oh, yes.
Agree that terminology is outdated. Emergency room.
Yeah. Anytime somebody says emergency rooms, it's really a department. I learned that as an emergency department nurse some years back. It was one of the first things I got corrected on. So, yes, it is emergency department.
Okay.
So
I'm just saying if they're going to spend money on something to be printed.
oh yeah, oh absolutely, absolutely. And I know that anytime that something gets printed, especially from a multidisciplinary committee such as this, there's going to be multiple eyes on it. So thank you for bringing that up, and for sure, we'll make sure that those things that get put out there have the correct terminology on them.
And Denise, this is Mary Ellen. I mean, we're going to see it anyway, right? We're going to be involved.
Oh, yeah.
So.
Yeah. Anything that comes from this committee, everybody on this committee would have eyes on. Before that. So the next thing on our list is information on the information packet, and that. Sorry, I'm looking for my notes that I just had. So basically, what we're talking about doing is an information packet that would be made available to Hall Hospital, yes, in emergency departments, and specifically for patients who report a sexual assault, right? So one of the things we had talked about before in this meeting was having the contents include the forms of both electronic as well as hard copy. And we talked about, basically having the Office of Victim Services, the Alliance, Connecticut Coalition Against Domestic Violence, providing information, brochures, and basically what they want to have in that information specific for these patients, as well as the DPH form that we just got through talking about, the Civil Protective Order screening form, the consent. Obviously, they have a copy of their consent from the kit, as well as their discharge instructions and the kit tracking form. But one of the things that I had reached out to Beth on, and Beth, I'm going to ask you to talk a little bit. We had talked about redoing the victim survey.
Yeah.
And so, Beth, I could ask you to talk about that a little bit.
Sure. So we, years ago, when the SAFE program first was started to go into effect, we developed a survey that basically was given to every single victim in the emergency department setting who got an exam through that program. We have basically, over time, we'll sort of put a self-addressed stamped envelope in there. We get them back here to the coalition. We put them into a SurveyMonkey survey, and we share them quarterly with OBS. One of the things that we talked about with Denise is that we can make this electronic also. I think that was one of the pieces that Denise is also really interested in, so that it can be something that is really easy. Most folks are going to have, you're going to have a higher response rate if folks are able to take out their cell phone or do it, right then and there, basically, and not have to worry about sending it in later. The other thing we talked about is the ability to use it as a survey that you can use statewide. So this was really only being administered to those SAFE sites, right, that were affiliated with the OVS program. And we really were asking specific questions in there about the experiences. What we would love to do, and I talked with my colleague Jessie here, who is a researcher and just is much more oriented to evaluations, who was not able, unfortunately, to join us today, but we talked a lot about different ways to broaden the survey. One, to just sort of see, sort of across the state, what the experiences are of folks who is administering, right? There should be some questions about what is the credentials or who's the person administering. And so we were really interested in helping in whatever facet, Denise would like us to both develop the survey itself, but then also we can administer the tool. So we have a SurveyMonkey account. It can come back here. We're happy to continue to report it quarterly to Denise and to this group. But really, I think that there's a lot of opportunity for us to get data from survivors and victims.
Absolutely.
We're not getting otherwise. And my guess is, I mean, with this, we don't get quite a 20% return rate, but what we do get is a lot of folks who tell us about really negative experiences and some folks who tell us about really great experiences. So no matter what, it's a really important tool to sort of learn some of the gaps and barriers to victims and survivors in general. And I think even if we don't get a high percentage of return, you're still going to get really critical information that we could bring back to the group and inform, best practices and things like that.
Thank you, Beth. And absolutely. And one of the things that I think has really allowed us to look beyond the SAFE program is the fact that we're now training folks statewide, not just as SAFEs, but even these, we provide these 3-hour hospital trainings that are becoming more and more frequent. And so that healthcare providers, whether they're becoming SAFEs or whether they're just doing that 3-hour training, they have at least some minimal level of knowledge. And the idea is to, as Beth said, to really hone in on a statewide level, this snapshot of where we're doing well, where we need to work. And the Alliance has been such a great partner the entire time that the SAFE program, as the response program, has been in existence. They pretty much designed the tool that we started out with way back, what was it, Beth, a decade ago? And have been doing the postage and collecting all the data. And so we thought, well, what a wonderful time to be able to just expand on that and make it a little bit more effective. So that would also, by the way, I mean, we've talked about this, but that would also be a part of this packet of information that we're giving. And one of the things that I was giving consideration to, we talk about this being the SAFE Advisory Committee and the packets and making this electronic. And one of the things that we talk about is the website to do this with. And Beth, I had not had a chance to talk to you, but it only makes sense to have all things lead to the Alliance with regard to resources and information.
Yeah. And we're really happy. We talked about that in the past, Denise. We continue to be happy to have him. We did that with the Track Your Kit. We have it. There's another campaign we're doing. We've gotten good at developing individual landing pages on the website. So we could have all of those resources listed there. Everything can link back out to individual organizations or other service providers. And the same thing with the survey we just talked about. We can have a QR code that lives right on, or the survey itself, right, that lives on the website. So we can make sure there's points of traffic directing back. So we continue to be very happy to do that, Denise.
Oh, I figured as much, but I kind of wanted to just put that out there. Does anybody else have any other thoughts or input, ideas, suggestions?
No suggestions, but I think, looking to broaden the amount of people that might, feed into the survey is a great idea.
Mm-hmm. So it continues to be, this work in progress, but I really think that this is going to, what we end up with is going to be a wonderful tool. And for everyone, it'll be wonderful for victims to be able to have a voice to help basically inform us of the care that they need to have, as well as identifying the gaps for all the different agencies, whether it's whether it's for SAFE or whether it's, for any of the agencies that are on this resource list for them. I think it'll be like a continuous feedback loop that will allow us to really improve. I think it'll take a little bit of time, but I think it has the potential to be a tremendous tool for all of us. So if there's no more questions, I'm going to go on to actually a different website. We have two different websites. And I want to say this because there's a tendency, not a tendency, but an opportunity to get the two confused. So we're talking in this in what we've been talking about is essentially, you know, a website of resources for patients who report a sexual assault. But now we're going to switch over to a different idea for a different website. And that's really about for healthcare providers. There's two schools of thought. Just, you know, we've talked about this at the last meeting a little bit, but I want to go back and refresh a little bit. There's two schools of thought that we're seeing with regard to healthcare providers and the SAFE program and the direction in which it's taking. Within the SAFE program and some outside the SAFE program, there is a real desire to have this statewide response program, which is literally every hospital in the state has a response program where trained SAFEs respond to that hospital. And it may not be their own hospital necessarily. It would just simply be an expansion of the current SAFE program. But what we're also seeing among those who attend the annual competency day, we're seeing SAFEs who really want to do a hospital-based program simply just for their hospital. They're not interested in being a part of the SAFE program as a response program. They just want to take care of their own patients. And we see both sides of this. So, and my guess is we'll end up pursuing both sides of this, but in order for us to expand as a response program, we actually need to staff it. We need to find the staffing for it. So one of the things that we had looked at was developing a website. And I'm going to see, I'll be honest, I'm not a whole lot of experienced at sharing, and I realize that some are on the telephone and will not be able to see, but I am going to try to share my screen here. Let's see. Can those who are on the visual, can you see this?
Yes.
Yeah.
Okay. So this is the Judicial Branch website. Anybody can go to this. Just for the sake of those who are on this meeting who are judicial, I did review what we could and could not do with Brenda Keene, who is our quality assurance person here. So in this line here, you see all these different links for those who have not seen this before. And in the middle are victims. So if you click on victims, it takes you to a different screen and you'll see that there's all kinds of services for victims. And one of those on the left-hand side of the left column is sexual assault forensic examiners. So if I click on that, it brings us up to the Office of Victim Services SAFE website as it currently is. And for those of you who can see this, it is essentially the audience for this are victims. And you can tell, you know, if you or someone you know, it starts off with saying, if you or someone you know was sexually assaulted, the Office of Victim Services Sexual Assault Forensic Examiners program can help. And this gives information about who qualifies for our services, where the participating facilities are, and what a SAFE is. One of the things that we had been talking here at the Office of Victim Services and talking with Brenda about what we could do to keep the audience the same, because we want to keep the audience geared towards victims. And yet you could see that if a healthcare provider went on here and they're looking for information about the SAFE program, what are they going to go to? They're going to go to this link up here that says SAFE, thinking, oh, this is where I can basically look for information about the SAFE program. But they're not a victim. They're a healthcare provider looking to become a SAFE or be a part of the SAFE program. And so one of the things I was talking to Brenda about was the idea of taking this page and creating another link on it, which would then create a whole other page and basically would say for healthcare providers. Now, just to clarify, you'll see up here it says service providers. That is medical, but it's more about compensation. Also, you'll see training up here, and that's really about all the training programs through the Office of Victim Services. But the most obvious one to click on is SAFE. So we're thinking of creating just a whole other, like almost like a button like link that if you're a healthcare provider looking for more information to become a sexual assault forensic examiner, click here. And of course, that would create the whole other page. Does anybody have any questions about what we're thinking about doing, or have any input or suggestions or ideas?
So this is Marielle for the Hospital Association. I think that's a great idea. I think adding a tab or creating a space for the healthcare provider to go to be great. I'm wondering, and I know we haven't gotten to this item on today's agenda, but would the list of safes that we're planning to have sort of published also be a part of that same page, or would it be on this
website? It certainly could be. It
Yeah.
certainly could be. We have not really gotten to the point of developing the website. It was more, what we've gotten to is basically where do we put it and how do we get it there? So that's kind of where we're at with the scheme of it.
Yeah.
But certainly that's one thing that could be on it.
Yeah, I mean, I think it makes sense, you know, the thought behind creating, you know, a space that's not necessarily a victim orient, you know, or I know we're trying to get away from the term victim.
Yeah.
But yes, it's still, you know, quite a terminology for you guys. You know, I think that makes sense to have a different page geared more towards providers who are looking for information.
Yeah. And so one of the things that we could do with this is we could provide the same information that is on the application, that is on the fact sheet. We could also create just basically an informational guide, an FAQ section. One of the things, and I should really say this just to be clear with everybody, when we talk about the judicial branch website or anything like that, we're talking about the only things that we can put on there are things that are like state agencies, federal government, or entities that have a contract with judicial. So like we couldn't put somebody on here, and this is true for the other website as well. We could not put somebody on here who doesn't have a contract or who's not state. And Denise, I know Denise Poncini, you're kind of on here. I don't know if you want to add to that.
I don't have anything to add. I think you're giving accurate information.
Okay, thank you. So the idea would be so that people would go to what is the most obvious link, which is SAFE. And here's what the victims are seeing, the patients who report a sexual assault. And over here is an entirely new website, a new page that could provide information that is, in much of which is actually already in existence. We don't really need to reinvent the wheel, but it would maybe provide them with the information they need to then inquire further. One of the issues, for everybody's sake, and this is one of the issues we do have consistently throughout the SAFE program's history, is people come into the program not really knowing what it is. For the longest time, we would hire people, they would sign the state contract, the request for information, or RFI as it's called, and then we would put them through the training. And then they would precept a case. Now they're having the opportunity to do the training first. They're also having the opportunity through this website then to get more information. And I think that's important for us to grow. And I'll just give the example of what just happened as an example. Between December of this past year and a couple of weeks ago, we had a total of 18 healthcare providers who were interested or indicated an interest in being a part of the SAFE program. They were all sent the fact sheet along with a little bit of information about the SAFE program, like the frequency of the RFI, the class dates, and things of that nature. Of those 18, when the RFI came out, 7 indicated that they were applying. The RFI closed on Friday, and a total of 4 of those 18 actually applied, and one of those lives 2 hours away in Massachusetts. So that kind of paints the picture of the difficulty in growing this program. And we think that if we had this website where people could go and get real information, and then they could then talk to me if they wanted more information prior to the RFI going out. So we continue to work on basically recruiting and marketing. And what I would like to ask you all, because I've been doing a lot of the talking, I would really love to know what you, if I've missed something that should be on that website, or if there's other ideas that you all would have to recruit, or information that should be on that website.
Denise, I'm looking to some of the nurses on here to sort of give you some feedback, but I can certainly work within our membership to ask that question of, the ED staff, what would you be looking for? Happy to sort of query our members and see if we can get a sense of things that we're not as a group sitting here today thinking of, but they're currently saying, this isn't where I can't find information on this unless I ask you or Denise or Pat or, so I'm happy to help in that way, but I'm hoping maybe others on, with actual.
Yeah, I know. I don't know if Heather's still here. She may not be. I know she's kind of, and we don't have a couple of our nurses. Alexis, do you have an idea? Do you have any thoughts?
I am still here. I had a hard time hearing the question. Thoughts on what was it?
So do you have any thoughts or ideas or suggestions about what should be on that website for information? And also any thoughts or suggestions about how to recruit healthcare providers?
Yeah, that's a loaded question. I guess I'm going to be honest. I think that I would be happy if they even knew, if I could disseminate the information that there is a site for them to go. I don't know how many would go to it, maybe for the most general of information, like where can they send a patient and what could they offer them for resources. But I'm not sure that there's, I guess I'm kind of racking my brain, but I don't know that there's that much more that emergency providers would need. Is that the kind of stuff you're saying?
Yes, or just information that could be on the website. I mean, we're going to come up with content, but
everything that people have said about all the general information, like what are the resources, who can you call, like information just about any kind of information really is gold. I mean, the more information, the better. I think everything that people put, like all the packet information, like anything that would be in a packet, I would make sure is on the website. I mean, people love that. If they do have a question, they'll search it. They'll go to a website and look at, like, what's this phone number? Or how do you do this? Or who could you call for a question?
Mm-hmm. Yes,
well, and if there's already an FAQ on there, that's half the battle, right? We don't have to field phone calls. We can just direct people to a comment.
Yeah.
Yeah. I noticed Charmise, and I'm sorry for calling people out, but I am. Charmise, we talked about putting a page in the technical guidelines for who to call. Do you want to elaborate on that a little bit?
So I'm not sure how much you want me to elaborate on it, Denise. You did have the idea of putting in a page of who to call. The technical guidelines are on the commission's website. And what I am doing, or what we're going to do, because the state is kind of realizing that all of the state web pages are difficult to use and cumbersome and clunky. So one of the things that we're doing is the technical guidelines will be listed in like a PDF. I think if you go there now, it's like you kind of scroll down the page and all 126 pages is listed, which is just weird. We're kind of doing away with that, and we're trying to make it easier for people to navigate. So like there's like a almost like I guess, like a directory page, and we're gonna set that up, but there are some small committees that are in place to make the websites more user-friendly, because the way that they are right now, in my opinion, at least for the commission's website, is it's not user-friendly, and if you're going there to look for technical guidelines, you'll find them. But it's not in a format that people say, okay, this is what I want to use, and we really want to get it in that format. So once I get a good handle on what we're doing with the commission website, I'm absolutely happy to share with OVS and what they do with the SAFE page. And I just agree with what people are saying with the more information you can put on the website, the better the website.
Yeah.
And I think, Denise, it's an opportunity for us to, again, link the technical guidelines here to the commission's web, you know what I mean? To have that continuity of here's where you go to read the guidelines, and here's more information about safes. And I think it's another good opportunity for OVS to have a portion of the website to talk again about the fact that training has to be done, in the state for safe personnel by OVS. It's another good opportunity to have a space for that, because again, we still have, some providers are still on the learning curve about that, because it's still fairly, it's only a requirement for maybe 2 or 3 years now that, they're still getting used to that. Oh, really? I can't, create my own training program without, somehow going through the SAFE program if I want to really call this person SAFE trained, right? I mean, so I think that's another piece. I'm sure you were thinking of that. I mean, I think once you have sort of a mock-up, it'll be easier to give you additional.
Absolutely.
Right.
Yeah.
Right. And
I
then
have,
if I could just
both Linda and Pat out, so but we will get. I'm hoping by September we'll have a mock-up for everybody to look at. And Charmise, to your point, the idea, just to kind of explain to folks, I was getting phone call. I do get phone calls. I get phone calls, all kinds of phone calls, and some of which, they're appropriate for me to answer, but some of which, as I've talked to Charmise, some of which are not appropriate for me to answer. And so we were talking about developing a kind of sort of a page of who to go to and about what page.
Right.
So as part of what healthcare needs to know.
And then Denise, if I could just add that I don't have, I know that the judicial has restrictions on, you can only link to other state agencies. I don't have that restriction. So one of the things that that we're going to do with the commission's webpage is to the Alliance is for example, the Alliance is a member of the commission, and so there will be a link to the Alliance's page and anyone else that's a member, because if they're sitting on the commission, the idea is that they have resources that are helpful to whether it's victims or advocates or medical professionals. And so we're going to make it easy for people to get there. So I don't have, we don't have the restriction. So maybe by the SAFE page linking to the commission page, we'll be able to kind of circumvent judicial's state agency only policy a little.
Yeah. So, I mean, I do think, I know we have contracts with the Alliance and also with CCADV and many other agencies. So we're not just restricted to state agencies, but we just couldn't put somebody's website up there that's a personal, program that they're running. It's just, that's different. But you're right. What this will do is it will help us to provide a continuity. And one of the things that I really look forward to having, and I think we're really headed in that direction, is to have a more seamless appearance of not appearance, but a seamless meshing, combining of all the different agencies that help victims of sexual assault, and kind of be clear about where to go and for what, as well as for those who want to provide those services. So I think as we move forward, I think all the different committees will really, literally, you can see the puzzle. It's like different pieces of a puzzle coming together. So I'm very excited about that. So, but any other questions about the website? Okay. So the next thing, and I realize it's a lot of my talking, and I do apologize. So we talk about the list of safes in the state, and we were trying to get through the annual competency days. Those are the mandated once a year training days for those who have trained as safes to keep their certificate current. This summer, we actually had, because of the pandemic and its impact on some of the classes, we had 7 scheduled. Normally we have 4. We've gotten through the first 4. And I would just want to share, I'm going to try to get rid of that and share my screen again. I want to share with you what we're doing. Can everybody who's got a camera, can you see this?
Yes.
Okay, so this is the agenda. It's a full day of training. We have a total of nearly, not quite 100, so it was more like 90 something safes who are attending these. It really is, it's fascinating to listen to them talk about the different cases that they've done. And what we do is we did do a review of the Public Act 19114. And by the way, that's a typo right there. That should be 1883 right there. I apologize for that. But we review the Public Act that basically governs their practice as safes. And I show them the Safe Advisory Committee. We actually have the website up. We show them the website and show them how they can actually get on there and actually watch it. They're invited that if they see a topic that or something that needs to be covered, whether it's by the Safe Advisory Committee or by the commission, they're invited to let me know about that because they're the ones doing the cases. They're the ones that are seeing the events that happen as they unfold. We also talk about the kit tracking form. We make sure who to go to. We send them to the Alliance. We point out the website and the phone number. And what we were finding out, I was talking to Daniel Lindgren at the lab about this a little bit. What we were finding out is that there were some misperceptions about who should be filling this out and who should be tracking and creating the accounts. Seems like in every group so far, we've had at least one person who said, when I ask who sets up the account, at least one person will say the nurse. And so we do correct that, and we send them to the Alliance as the go-to page for the kit tracking. So we do our legislative update, and then we actually do, believe it or not, we actually do in the entire morning. We go through the International Association of Forensic Nurses 2018 education guidelines, which is the current version. And what we do is we ask questions related to their cases so that they can take what they learned, and they have to give examples. They have to give examples for each of these. We kind of sort of pick and choose which outcomes. We review the learning outcomes, and then we pick and choose which specific questions to ask them to relate examples of what it is that they learned so that they relate the class to what they're actually doing. We also hit the highlights of the national protocol, which is a lot of information. We tell them it's general, it is not state specific, but it does provide them with there's a really great section on victim-centered care in there. It gives a lot of background that we wouldn't be able to give in the class. So we tell them it's general information, but it's good information. And then you take that and you apply it specifically to the state that you're in. And then after we take a little break, and then we spend an hour going over the entire technical guidelines, beginning to end, with emphasis, by the way, on things like, we actually read the case reviews in there for the legal aspect, the case laws, the decisions, and why those decisions were made. We basically read them right out of the technical guidelines, because this is the part where they get stuck. They don't understand why other people can't be in the room and what happens, and they don't understand about law enforcement being in the room. In many of them, we really have to make sure that they understand that their role there is that of healthcare professionals, because there are people who come into the classes who basically I want to advocate for the victims. I want to do this. I want to do that. And it's not, we tell them this is not CSI. This is not, you're not an arm of law enforcement. You're not a victim advocate here. You are a healthcare professional. And so we really go over that from the education guidelines, from the national protocol perspective, and then from the technical guidelines review perspective. We have yet to run late. We actually get done on time and we break for lunch, and then Pat takes it over in the afternoon. They each have a kit that is in front of them. They are required to practice and to demonstrate each and every step. We have each other, we do role play, and we do all the way from the beginning, all the way to the documentation, from triage all the way to discharge. And at the very end, we talk about how you keep your practice up to date. We talk about attending the quality assurance meetings that they all get invited to. Anytime there's a speaker, they get invited to that. We talked about professional organizations. We talk about webinars, peer-reviewed journals. We talk about, maybe if they want to sit in on a sexual assault trial. We have victim advocates who know the schedules, so we go over a number of things and give them a number of resources for keeping their practice up to date. So it is a full day. It does take the entire day, but some of the comments is still the best training ever. I actually just got a phone call on my way into work. Somebody who had just finished her first case, had just attended this. She was so excited and the reason why was because she felt like she knew what she was doing. She had to call and say, I actually knew what I was doing, and I was able to answer questions, and I was able to do this and to do that. And it really shows the need for not only the training, but also for the refresher training. They do bounce cases off of each other. They do compare their cases with each other, what they have versus what they don't have. The training for their hospital emergency department, all of that comes into play. And it's a huge opportunity for us to identify the gaps in their training and in their education, as well as what we're doing well with. So when we add those numbers, though, when I did a count, and I will tell you that the total number of SAFEs in the state of Connecticut, those who have registered for the annual competency day, plus the ones who are currently in the SAFE program, total 106 SAFEs in the state of Connecticut, which is great. There are maybe a few more out there. Like we have lost some who technically would still qualify as SAFEs, but some of them have moved out of state. Some of them are attrition. We do have an attrition from this. Some have moved out of state. One person retired. Another person had serious health issues, wanted to continue, but her health issues prevented her from doing so. And then there's one person we really can't get a hold of. We can't reach that person. We can't find that person. So one of the things we are doing, and as part of the annual competency day, is we're asking them to give us their updated contact information, their email addresses, and letting them know that for them to keep their certificates up, we have to be able to reach them. We can't train them if we can't reach them. So,
it's Marielle. I'm just wondering, out of the 100 or so that you just retrained, how many are in the SAFE program for you guys?
We have a total of 18.
Okay, so a lot of those are hospital.
Oh, the vast majority are hospital based, which is why we're looking to increase that response program interest. Because, as I said, there's a lot of people who want the training, but not necessarily wanting to be a part of the response program. Of course, to be fair, in the first half of 2020, we had 27, and the pandemic was a major factor in us losing folks. And again, we just had four others who applied, and several others who have actually said they're planning to apply this fall, but here's why they didn't apply this time. And I there were good reasons. So with that said, Pat, who's not here today, has been working on a train the trainer program. We're training safes who are experienced to go out and train in the hospitals, to do these 3-hour trainings, as well as to do advocacy trainings. And one of the things she's been looking at is provider training, because we can't seem to reach the providers. So she reached out, she found out from DPH that is a requirement. Certain training for CMEs is required for providers in Connecticut through the Department of Public Health. So Mariel, I did suggest that she reach out to you, and I've asked you to share a little bit about what you two talk about.
Providers, are you talking about physicians and advanced practitioners?
Yes.
And nurses.
And nurses, advanced practice nurses, yes.
So Pat reached out. So
I'm sorry, what was that?
We referred to PAs and APRNs as advanced practicing providers. So the emergency physicians at least say APPs for advanced practicing providers. I wasn't sure if you were talking about APPs and physicians or somebody else when you're saying about DPH. And I mean, we all need to do a certain number of CMEs per year, but one of the hours has to be regarding domestic violence, but it doesn't have to be specifically sexual assault or.
Correct. It's an option. Right. It's an option for you to cover that requirement. Yes. Yeah. So that's why Pat reached out. He thought it would be an incentive, right? If there's something out there that providers have the option to choose something that will provide them. Yes. So I think we're still just in the initial conversations with Pat on this, and I'm actually really excited about it. For those of you who don't know who I work for, again, I'll just reiterate, I'm the representative for the Hospital Association, and so we often work to provide education opportunities to our members. Some of them provide, continuing education credits. We don't accredit programs as an organization, but we are willing to work through accreditation bodies to obtain credits for programs we offer. And we usually only charge, for programs that we do that for, because we're just trying to cover the cost of, obtaining the credit. So we don't pocket the money for it. It's just so that whatever the fee is, the person's paying, into what they're getting out of the program via credit. So we're looking to offer this, and Pat has graciously offered to, her time to provide this. So again, it's not necessarily for the safe people, but they could join us too, right? Anybody who's at the hospital doing kits on patients, this is the audience we're looking to reach, so that we're allowing opportunities for those providers that may just be working in the emergency departments, but who may, encounter a patient that's reporting a sexual assault and have to do the kit because maybe they don't have somebody on call from their hospital staff who's a trained safe at the time, or they're already busy, or they're not a program that goes through the SAFE program. Even if they are, perhaps the SAFE program doesn't have somebody in the moment they're requesting. So again, we want to try to reach those other providers who still need a refresher on how to work through the technical guidelines and provide the best possible experience for the person who's reporting the sexual assault, requesting and consenting for a kit. So I think we'll have probably more details to provide as Pat and I and our education team work on this. I think, the problem too, of course, with emergency departments is there are a ton of turnover. So no matter how many times we offer this, I think it will be something that's always going to be needed by somebody. And I think we're right now maybe looking to do it in a virtual way because, again, more success in not taking somebody away from their shift, having to come physically in person. And there's not necessarily like for the SAFE training where there's obviously a hands-on, this is going to be less hands-on, this is going to be more informational. So we don't necessarily need to all be in the same room together. And I think we can explore opportunities to record it and maybe have it available and still offer opportunities for live question and answer session. I mean, I think there's a lot of room for doing this in a really useful way for the providers, and again, offer up the option to, obtain continuing education credit. So unfortunately, I think the program might need to be longer than an hour though. So I wonder, where we may be offering more than an hour's worth of credit, because I don't know that we're going to fit everything in quite 1 hour, but we'll see what we can do about that. Anybody have any thoughts, questions?
But even if you're able, it's Alexis, even if you're able, if it's 2 hours, that's fine. The goal is just to fulfill the 1 hour of mandatory domestic violence topic. Like, there are lots of topics. I mean, there's 6 for Connecticut, as you know, but like and I can't think of one, I don't think, because unless you could get it for risk management. I mean, if you could do if it's a 2-hour program and you could fulfill 1 hour of domestic violence and 1 hour of risk management, that's pretty worth it. It may be stretching it, but if it's a 2-hour program and you get 1 hour for each, that would be pretty great.
So you're talking about bundling it a bit.
Well, if you're saying it's more than an hour, Marielle was just saying it's more than an hour. I can pretty confidently say, I mean, unless community emergency physicians are that much different. I mean, I know the academic emergency physicians are not going to pay for CME because we get a lot at the bigger academic facilities. Community physicians probably would elect not to pay also if it was something free. However, if it's something on the DPH site or somehow connected that's free, and for 2 hours you fulfill 2 of the 6 required hours for Connecticut, that's like a lot of bang for your buck, and it would be easy. Once one person or a few people do it, the word would get out and a lot of people would hit it and do it. But that's just for physicians, and I'm not sure what the advanced practicing providers have to do. I mean, I know they have to do CME stuff, but I don't think they have the 6 hours of specific topics that we have to include.
So I think, as Marielle said, we're really in the beginning conversations, or Pat and Marielle in the beginning conversations. I think one of the things that we had run into, which was very understandable, was that our safes would try to explain how we were supposed to do things, by the technical guidelines, by the education guidelines, and it had to do, and I think some of this had to do with the fact that you had a situation where nurses were trying to tell providers how it should happen, and it didn't seem to matter how it was done. Just the fact that you had a nurse kind of sort of telling a provider how to do something didn't resonate well with quite a few, and so we were trying to find a way to mitigate that, and to also make it appealing, make it something that they wanted to do, and wanted to know more about. And Pat, being a nurse practitioner herself, she knows more about continuing education, because, as you know, registered nurses in Connecticut are not required to do continuing education. But she was aware of it, so she started doing some research and happened upon this. So she reached out to Marielle. With my knowledge, she reached out to Marielle to at least begin the conversation of how do we go about doing this. And so what I'm hearing you say is that it might be more of a value if it was combined with another training for that amount of time, where they feel like they're getting the value for that 2 hours.
I guess what I'm saying is it really depends on what the goal is, and I guess it really depends on what the goal is, and I think that when you can couple things with a lot of bang for your buck, we're way more likely to do it. It's in some respects, a small population. We're talking about emergency physicians and then advanced practitioners. Unless you're trying to get all other physicians, like trauma surgeons may run into this, or critical care, like intensivists may run into this. You know, I guess it really depends on who your audience is and your goal, from my perspective.
No, I understand what you're saying. I also think we're maybe trying to combine too many things in one. I think maybe we start, and we can always explore further. We can talk more with, you know, CSMS and some other folks about the providers, but I think maybe the hole that we're trying to fill right now might be more, Denise, and I can talk with Pat about this further. We can come back to the group, but I think the bigger issue is getting more ED staff, whether it's a nurse, you know, an advanced, you know, an APP, a provider who sees, you know, victims, patients who report. I think right now, maybe the bigger issue is to try to get more opportunities to get staff who turn over a lot, opportunities to understand how to do, you know, how to do a kit for somebody who requests it in a better way in case they don't get it safe.
So Marielle, that, I guess to me, that's a bit like, I just have the question of, at least at my institution at Hartford Hospital, and I'm pretty sure this is going to be true at a lot of places, but like the nurses don't do it. Like if there's a safe that comes in, fine. Otherwise, it has to be the physician or the APP. Is that not true at a lot of the other community hospitals?
I don't know, Denise, do you have a better, I don't really know, to be honest. I would have thought there are times when a nurse is doing a lot of the kit. Maybe they bring a provider in for some aspects of it, but I don't know that it's 100% to the physician.
Right.
There are, I think in most hospitals in Connecticut right now, the provider is being brought in for the genital portion. I know that there's a couple of hospitals that have developed policies with their risk management to allow safes to be able to function in that role. That really should be the norm because that's actually part of the role of the safe. However, it's you know, it's an evolution. It's you know, it takes time to grow into something. So we're not really pushing it, but what we are trying to do is to, you know, not just have the nurses be the ones to be the go-to people about the care of a sexual assault patient, but also to have the providers, you know, have some knowledge at least of what the nurses are doing or how it's done, or, you know, the technical guidelines, even to know that they exist, because so many people don't know that they exist. And, you know, it's just different groups of folks are in different places along the spectrum, and we're trying to get everyone more in alignment with each other, if that makes any sense.
Yeah, I mean, it makes sense. I guess I'm trying to think of how, like, as the emergency physician kind of rep, what I could do or what I could offer. I'm not really sure more if there's this kind of spectrum. To me, it's like the emergency provider's own responsibility to know stuff, like, you know.
Yes, and
like knowing, it's the kind of like knowing policies of your hospital. You know, when my own colleagues don't know something that pertains to our own emergency department, it's frustrating. So I don't know. I mean, it's, to me, it's like medical knowledge. It's kind of like a competency thing.
You're exactly right, and that's exactly how we're trying to. I don't know if we're trying to frame it, if that's the correct way to put it. But you know, you can't. My opinion is you cannot have too much education. So anybody, you know, if we could find a way to make this appealing, to create value for it, to get folks to attend who are at the provider level, and I'm talking about nurse practitioners, because, you know, registered nurses, you know, we talk about them as healthcare providers, but when we really talk about providers in this context, it's really more of an advanced practice PA and physician level.
Yeah, I
So-
mean, all of us have to do education, so that would be good. I mean, there are hospitals, like at Hartford, the APP, so the PA/APRNs, they have their own education stuff. I mean, their boss, their director, like, I'm sure would welcome like an hour CME like talk if it's
Sure.
engaging, etc. They'll get credit. And it happened, you have to schedule it 6 months out, but I mean, you could schedule and say, hey, we want to be your 1 hour education lecture in November, and they'll help you get credit. I mean, get the CME so that and then you get your information out. That's easier than the physicians.
So I think we were
Yeah.
looking, Mariel, we were talking about doing it a couple of times a year, just kind of sort of almost permanently, just making that an
Right.
offering.
I mean, if it provides value, then I think we would, we're, instead of having Pat, so I think the point is, right, Pat knows she could go to a hospital and say, let's do this together. But instead of just focusing on an individual hospital offering it, it would be through CHA offering it a couple times a year. And we would work on getting the credits applied and do the credit work and provide that to the members that attend, so that, not individual hospitals are having to work on that. But what I'm hearing from Alexis is perhaps that'll be successful. Maybe it won't, because they already have their own agenda on doing some of that. But I think all we can do is try it and see how it goes, and, learn as we go if we need to tweak things. I think, I still think it's worth us trying to do something to help educate.
Are you saying in person? Sorry, maybe I missed it. I thought it was something like you're saying in person, or like electronic or video, like something that you could repeat.
I think we're thinking about offering it virtually, because I think, again, that's probably going to work better for providers to be able to just, click on and get onto the program, whether we do it in a report, pre-recorded, or we do it live, whatever works. But, I think we're still open to figuring out how that all goes. But I don't think we're looking to have, because again, they don't need to have hands-on thing go on. It's really more informational than it is. So they don't need to be somewhere physically, which is going to definitely not get the draw that a virtual opportunity would provide.
Okay. Yeah, I think that's great. I mean, and you, if it ends up that CHA, like it's whatever, however you want to deem it, like not robust or not like the attendance or whatever. I mean, between Hartford Healthcare and Yale, if you just even engage those two, I'm sure they would do a CME program virtually. They love the recorded ones that people can look through, and they would offer it, and you would hit a ton of hospitals that way. I mean, you're missing very few that way, like the Danbury Western people, the ones down by New York, but there's very, Middlesex. There's not a lot that is not, the great majority are HHC and Yale anyway.
Right. Yeah. I mean, but we, as CHA, we offer it to all, and right now all hospitals are, in the state of Connecticut are members. So, we would be hitting everybody by virtue of, we wouldn't certainly limit.
Just offering it. Yeah. No, I'm saying if it doesn't work and you're like, hey, we're not getting a lot, you could always do it through Maybe,
Denise, I can talk with Pat about maybe 2 tracks, right? Maybe we do hit more of and this could be a free training, right? One that doesn't require people to get CMEs or pay for it. One that's more geared towards, okay, so you don't have a safe responding, you can't activate the program, do all the things you need, right? And then still do something else more along the line of attracting providers to sort of get in the know and perhaps, provide the credit incentive to them to join. We can always talk to, if Pat's willing, we're willing. I don't think that's a problem. It just depends on what she's willing to offer. And I think, both come with the opportunity to maybe even do it once and record it and see how that goes, so it doesn't necessarily mean her time is going to always be drawn on.
So we'll continue to move forward, and I'm hoping that at the September meeting, we'll actually have more information, because, we just started this discussion, this past week, Mariel?
Yeah,
so,
2 weeks ago, maybe.
So last week. So, I mean, it's not like we've had a lot of time to really, develop this into some sort of robust idea. So hopefully in September, we can, flesh this out a little bit more and have more information. to provide. So any other questions though about anything that we've talked about so far? Okay, so we're getting through this. We're actually doing really good on time. So the last thing on your agenda is new business. Is there anything that new that people would like to bring up? Or did we have we talked everybody out? Okay. So I think, based on all the conversations that we've had over the past hour, we've actually covered a lot of ground. It's obvious that we have a lot going on all good stuff. So, so the next meeting is Wednesday, September 8th, in keeping with the previous pattern of meetings. It's Wednesday, September 8th at 2 p.m. The meetings for the rest of this year, which would be at least the next two meetings, are going to still be virtual on Teams. I can't speak to next year. We don't have that yet. It's a little too early to talk about that yet, but at least for the remainder of this year, they will be virtual. If anybody doesn't, if I can get my words right, if nobody has any other things, topics to bring up, we will adjourn at 3:08.
Good meeting.
Yeah, thank you all for all your support and conversation. It's been a very rich meeting.
Thank you all.
Thank you.
Here, everybody.
Bye,
Take
everybody.
care, everybody.
Bye.
Bye-bye.